Thank you, Chairman and Co-Chairman. Today, I would like to present surgical management of pulmonary atresia with ventricular septal defect. All of these names have a same meaning. Tetralogy of Fallot with pulmonary atresia, the PAVSD, Tankard type 4, or the pseudo-Tankard arteriosus. The pulmonary atresia is the absence of the functional continuity between the right ventricle and the pulmonary artery. The pulmonary blood supply may mostly come from the ductal arteriosus, but 20 to 40% is come from the major aortopulmonary collateral artery, or in the abbreviation is the MAPCA. The PAVSD MAPCA is one of the most challenging of all congenital heart disease because of the mixing lesions, high variations of both anatomic and physiology. The challenging points of the elusive disease are anatomic and physiologic heterogeneity. From anatomic heterogeneity, 20 to 25% of these patients are absent of intraprecordial pulmonary artery. There is high variations of both native pulmonary artery and MAPCA. The pulmonary blood supply in individual lung segments in the same patient may be single or dual, and all the anatomy can be changed by it. From the anatomic point, the physiology is also complex. It is total mixing lesion with individual pulmonary vasculature segment by segment, with very high variation dependent on anatomy. The goals of management include: first, achieve the true ventricular circulation. Second, achieve the lowest possible right ventricular pressure, because the right ventricular pressure to left ventricular pressure ratio is a predictor of the possibility of the hospital death. From the graph, you can see that if the right to left ventricular pressure ratio at the end of repair is high, it means that the patient has a high probability of the hospital death. There are two concepts of the treatment in this kind of patient, depend on the vessel that you trust on. The standard management from the old day, we start with unifocalization or the state operation. In this operation, we trust on every single vessels that supply the lungs. It means that you try to unifocalize the vessel from the individual lung segment into the only one source of blood supply, and then you perform the centralization again. And the new concept is the pulmonary rehabilitation. In this concept, we trust on only the native vessels, not only but mostly on the native vessels. By this concept, we try to augment the pulmonary blood flow to the native pulmonary vasculatures and hope that the native pulmonary vasculature can grow and supply the lung entirely. And this is the early experience of the state operation. The first, we try to unifocalization of the pulmonary vasculature from the left side, right side, and then perform centralization. By this concept, it means that you have to do multiple operations. How about the results of the state operation? It has a modest improvements in hemodynamics. The right ventricular to the left ventricular pressure ratio is stay around 0.5 to 0.6, not as low as we want. And the chance of complete repair is around 42.5 to 64.6%. And there is a high chance of poor pulmonary arterial growth, and the segmental vessel patency we cannot guarantee. However, Professor Frank Harley from Rosyth Packard Children's Hospital tried to make some improvement in the unifocalization. He performed the single-stage unifocalization. This operation attempted to recruit all of the source of the pulmonary blood flow in midline with the single state whenever possible. From his study, he can achieve the complete repair nearly 90% with a very low RV to LV pressure ratio, only 0.35. However, you can see from the picture that this operation is quite complex, and you have to perform this operation in the very early stage of life. And this picture shows the results of the study around the world. You can see that from Frank Harley in 2017, with the single stage unifocalization. Right now it is the best technique and also achieve the lowest right ventricular to left ventricular pressure ratio. And now we come back to talk about the MAPCA. What is MAPCA? If you look at the anatomy of the MAPCA and compare to the anatomy of the bronchial arteries, you can find that there has some correlation between each other. It means that the MAPCA is an enlarged bronchial artery. And if we look deep down into the histologic level, this picture showed the MAPCA that connect to the native pulmonary artery. You can see that the MAPCA have a completely different histologic anatomy when compared to the native pulmonary vessels. The wall of MAPCA is thick and have intimal perforations and the cushion formations. In contrast to the native PA is still thin without any intimal proliferation. From the MAPCA anatomy and the new knowledge, some doctors developed the pulmonary rehabilitation concept. By this concept, we trust on the native pulmonary vasculatures mainly. There are two techniques were developed across the different continents. One is come from Europe, from France, by Professor Unifocalization. This technique, he performed the right ventricular to the main pulmonary arterial patch augmentation. And another technique is come from Australia by Professor Christian Brisert. This technique, they use the shunt, central shunt, to augment the pulmonary blood flow to the native pulmonary artery. The objective of the pulmonary rehabilitation is that they try to augment the flow to the native pulmonary artery and try to promote the growth of the native pulmonary artery. If the native pulmonary artery have a high enough pulmonary blood flow and also the high enough pressure, the collateral will close spontaneously. And if we perform the systemic to the pulmonary arterial shunt or some connection between the ventricle to the pulmonary arteries, means that we have access site to the pulmonary artery where the intervention. So it's quite easier for the re-intervention like coil embolization or the balloon angioplasty. The pulmonary rehabilitation have high diversity. This technique is not just only the shunt or the conduit, but the shunts also divide into the central shunt or the other shunts. In the other end, the RV2PA continuity can be divided into the non-valve or patch augmentation like in France, and in the US they use a valve conduit like a homograph, femoral vein, aortic or the pulmonic homograph. There are several facts and myths about pulmonary atresia and VSD and MAPCA. The first is about the large MAPCA. Most of the doctors think that the large MAPCA can induce the pulmonary vascular obstructive disease, but actually the large MAPCA has tend to be stenosed, so that lung segment can be protected by itself. And some doctors believe that most of the PAVSD MAPCA has no central PA, but actually the group that doesn't have a central PA is confined in only the group with the bilateral ductal arteriosus. Some think about that the very diminutive pulmonary artery cannot grow, but actually it's always grow if we put enough flow and the pressure into that vessels. And also about the very diminutive pulmonary artery, they think that it will be incomplete embolization. But after we augment some flow into that incomplete embolization vessels, it has a potential to connect to all of the lung segments. So the Australian group, they developed the central shunt. First development is a Melbourne shunt. The Melbourne shunt, they disconnect the main pulmonary artery from the right ventricle and then connect end to side to the ascending aorta. However, with the technique, the problem is that the angle between the main pulmonary artery that connected to the ascending aorta with the right pulmonary artery is quite acute, so it tends to be stenosed and have a chance of thrombosis. So there is a modification by Hillel-Lux modification. They're using the interposition graph with the side to side from the ascending aorta and end to side to the main PA. And after the first stage, until 4 to 6 months of age, if the pulmonary artery is not growth enough, they will change to the RV to PA conduit. It depends that you can use both non-valve like the Cortex conduit or the banded constrictor, that is the valve conduit. From their early experience, you can see that they can achieve complete repair 12 in 20 cases and wait for repair for 6, and the patient have a likelihood for palliative balloon too. From the picture, you can see that the PAE from the start is quite diminutive. It's quite small, and then after we augment the flow, the PA can grow and it can distribute to entire of the lungs. On the other end, they use the right ventricle to the main pulmonary arterial patch augmentation. You can see from the picture that the patch is augmented from the right ventricle and going up to the main PA. It means that in this operation you have to use the cardiopulmonary bypass in the very early stage of life. After the first stage operation, you can see that the first stage they perform in 20 cases, but during the first stage to the complete repair, there are multiple operations that you have to do, from the embolization of the MAPCAs, the unnecessary vessels, unifocalize in some big MAPCA that maybe we need to re-implant it, and then some cases have to stent the pulmonary artery, some cases have to perform the angioplasty, and then they can achieve the complete repair. And the other variation of this technique is proposed by Professor Richard Jonas from US. This technique, they use a valve conduit, like a pulmonary homograph, pulmonary vein, aortic. The mean diameter is around 10.5 millimeters. The another benefit of the conduit from the right ventricle to the PA is that you can achieve the pulsatile flow to the native pulmonary artery. The pulsatile flow can augment the pulmonary growth better than the constant flow like a shunt. And with valve conduit, it means that you can protect the regurgitation from the pulmonary artery to the right ventricle. The chance of the right ventricular failure will be lower than just a non-valve conduit. And by this technique, they propose that they can achieve the similar pulmonary arterial growth left side to the right side around 0.43 millimeters per month, and can achieve the complete repair nearly 90%. After we achieve a good enough pulmonary vascular bed, the next thing we have to think is about the closure of the VSD. The first development about the criteria to close the VSD in this kind of populations, we start with the anatomic criteria. First was proposed by Pucker. He used the central PA. If it's more than 50% of the predicted normal, it can be the VSD can close. However, the central PA in this kind of patient is the man-made. It means that actually this patient doesn't have a main PA. So this criteria is not acceptable. And then Professor Roger Me proposed about using, if we can centralize more than 2/3 of the lung segments, it means that the predicted right ventricular to left ventricular pressure ratio should be less than 0.7. It means that we can close the VSD. And some doctors propose about the Nakata index. However, the Nakata index in this kind of population is quite hard to measure because the lung segment is come from the different source. So Professor Hallett proposed about the total neopulmonary arterial index, TNPAI. If it's more than 200 square millimeter per meter square, we can close the VSD. This technique we measure the pulmonary arterial segment by segment and then plus all together, sum it up, and then divide with the body surface area. And then in 2002, Baker proposed about if we can centralize 15 out of 20 pulmonary segments, we can cross a VSD. However, all of that criteria is the anatomic criteria, but it's not the hemodynamic, it's not physiologic. To achieve the physiologic criteria, Professor Harley used a pump the blood at a rate of normal cardiac output, 2.5 liters per minute per meter square, and then measure the pressure in the PA. If the mean pulmonary arterial pressure is less than 25 mm mercury, we can predict that RV to LV pressure ratio could be less than 0.5. It means that we can cross the VSD. The Toronto group in 2009, they used the number at less than 30 mm mercury is also possible. And again, this is the overall results around the world from the different strategies. You can see that even in the state unifocalization, some institutes achieve the very good result, some institutes cannot achieve that result, and even the pulmonary rehabilitation is also like that. This picture shows the summary trends of the different strategies of Tetralogy of Fallot, PA, MAPCA. From the first end, the unifocalization, you can do the standard state operations. First unifocalization and then centralizations. It means that you have to perform the multiple operations, and the MAPCA patency cannot be predicted. And if you perform another variation of the unifocalization, it means that the early state, single state unifocalization, it means that you have to perform this operation in the very early state of life. The technical difficulty will be high, but however, you can achieve the best result, but it depends on your hand. And on the other end, about the pulmonary rehabilitation. First, if we use the systemic to the PA shunt, like a center shunt or the other shunt, this means that you don't need to use the cardiopulmonary bypass in the early state of life. The mortality, the morbidity in the first state will be lower, but you need the multiple operation for sure. And also, if you do the central shunt, you have to perform multiple restenotomy. And if you use the right ventricular to PA continuity, even with valve or non-valve, it means that you have to do the open heart surgery in the neonate, use the cardiopulmonary bypass in the early state of life. With the non-valve, you can have a risk of the right ventricular failure. However, you can achieve the pulsatile flow that can predict more growth of the pulmonary artery. But if you try to avoid the right ventricular failure using the valve, you have to face the shortage of the homograph, especially in the country like us in Thailand. And this picture shows the individual strategies that's distributed in the institutes around the world. You can use both the central shunt, you can use both the PA growth, pulmonary rehabilitation with the non-valve, or you can use the valve. It depends on your familiarity about which strategy that is suited for your institute. From the high variation of this disease, the complexity of both anatomy, physiology, and also the strategy. The best way to approach this kind of patients is the Sun Tzu, the art of war. The Sun Tzu concepts have the three concepts. First is to know your enemy. Second, know yourself. And third, know your environment. If you know three things, you can win the war nearly 100%. Know your enemy means you have to know your patient, the anatomy, the PA abilization, the significance of the MAPCA, and also the patient conditions. Know yourself, it means that you have to know your knowledge, you have to know your skill, you have to know your hand, you have to know your plan, your strategy, and your age and your health. And last, you have to know your environment. This means your team, the perfusionists, anesthesiologists, staff nurse, ICU, everything, institute, instrument, your reimbursement, everything, and also the patient's family. If you know all the things, You can treat this patient with a good strategy. Thank you for your attention.